Hey, this is Dr. Jurgis with Move to Improve. Today we got a very cool guest, Dr. Ali Chatha. How are you doing today?
I'm just recovering from Stampede, but pretty okay. Thanks for having me.
Preaching to the choir here. Greg, how you doing?
I'm good. I'm a little older and don't love the Stampede anymore, so I'm actually good today.
I feel like we have every kind of Calgarian here. So you are the Associated Medical Director for PCN, Mosaic PCN, which is pretty cool. Can you tell us, what that is?
For sure. So I'll just give a quick brief introduction. Grew up in Toronto, went to York University. My profs were surprised that I got into med school from York because anybody who has gone to York University, if you can lift a fork, you can go to York. Got into Calgary Med School, moved here, did my family medicine residency at University of Calgary. Luckily was chief resident, and that kind of helped me transition into full spectrum family practice right out of the gates. I went to the urban program, but got into Strathmore family medicine pretty much. So I had a full-on family practice. I worked at the nursing home in the town and also took call at the hospital as well as working in ER. Transitioned into emergency medicine, started working in Strathmore ER and Cochrane Urgent Care, gave up on family practice for a bit, and then came back to family medicine and started working with my brother, who's also a family doc, here in Calgary in Bridgeland at Oasis Medical Clinic. One day, one of our practice facilitators, as we call them, they're our multidisciplinary team members, came to our clinic and said, well, you're part of our primary care network, Mosaic. We have to tell you about the programs, et cetera, et cetera. Thought that was super cool. And then a couple months later, she's like, I think you should get involved with our leadership team. And I realized that I've been working for 3 years with the PCN during the pandemic, and they just wanted a fresh face. Thought I had no chance, applied, had a couple of interviews, and the next day, my MOA, my front desk staff, tells me that there's a doctor to see me after my second interview. And whenever they say a doctor's here to see you, sometimes it's trouble. So I was like, oh my God, what did I do now? So I go in the next room, and it was one of my preceptors, Dr. Kangong, and she was there to tell me that I was the new associate medical director. So that was super cool. She was one of my teachers at the Sunridge Family Medicine Teaching Center. So it was really good to have that full circle, training in the Northeast, and then doing the Mosaic PCN in the Northeast, Southeast Calgary. Since then, I'll speed up. I've been involved with the pain management clinic. So we have revamped our pain management clinic at the PCN. And we were recently at the Canadian Pain Conference in Banff, where Evan, who works with me at the pain clinic, had a poster presentation. So lots of cool things happening. And that's pretty much a brief snapshot of what I've done so far.
It seems like everywhere I go, you're always doing something. So that's, you're everywhere right now. It's great.
You've had a busy career. Like, how many years have you been in practice?
I finished my residency in 2015. So this is my 8th year of being a family doc.
Yeah, well.
Right on.
So for listeners, can we just define our PCN a little bit? So I know it's primary care network. They divide them up into regions geographically, I guess, right, throughout Calgary. So we have Foothills, we have Mosaic, we have a number of them, right? But Mosaic, as you were just saying, is now the largest, okay?
Yeah, so primary care networks came around with the idea that all patients need a medical home. We had all these family docs working in different pockets. There was a lack of collaboration at times, lack of centralization of resources. So if I needed a dietitian and I'm in deep Northeast, I could not get a dietitian. My family doc is referring me to Foothills, for example, to get a dietitian. I don't even have a ride. How am I going to get to Foothills? So what the government did is they created these primary care networks based on geographical surroundings, and then you have centralization of resources. So our primary care network, for example, has a social worker, a dietitian, a registered nurse. We also have registered nurses going into clinics that have a high turnover. So recently, our clinic has gotten a PCN mandated nurse that helps us with chronic disease management, for example. Every primary care network has its unique qualities and quirks. So I recently found out that a bunch of other primary care networks across Alberta have pain management clinics. We are taking on initiatives like Alberta Cancer Lung Screening Project that I'm also part of. So all these things are coming to my mind where the government gets centralized place where they can send resources and feel that there would be a structure that can implement and use those resources effectively.
Nice. Very cool. So it's an opportunity to open up the referral source for these physicians or these offices, and then also to make sure that these resources are getting properly distributed. They're creating incentives for things that need to be emphasized within the network, and
better patient access, right?
Totally. And for example, and the unique challenges of that geographical area. So as Greg was alluding to, our primary care network now has become the largest with, we have just gotten an update, and we have nurse practitioners. We have 400 physicians in our PCN with about 300,000 patients, and that number is old, so I think the number has increased. Our PCN is unique in the sense that it runs our refugee clinic. So the refugee clinic that takes refugees from across Calgary is run by our PCN. We have low-risk maternity groups. It's a huge operation. When I sit on these meetings about, just the leases for clinics, for example, it just blows my mind how big this operation is. And today our goal is to talk a little bit more about how we collaborate, and primary care networks is a prime example of this. We collaborate with other physicians. We collaborate with physicians who have specializations in refugee health. So what was happening, for example, in our refugee clinic was that the refugee clinic was getting overwhelmed. Refugees were coming in. They were getting used to this model of coming in, seeing a physician who's paid on an alternative remuneration plan, so they can spend 40 minutes with them, fill out their forms, social work, everything under one roof, which is great, which is awesome. But once they become completely integrated, it's their second year, third year, there's no need for them to take up those resources. So what our primary care network pretty much did is we identified clinics that have the opportunity to take these refugee patients on once they have been stabilized and transitioned. So our clinic, for example, gets a bunch of these refugees, and with the influx of Ukrainian refugees, luckily I have 2 nurse practitioner students in my clinic right now who speak Ukrainian. So it's quite interesting to see patients coming in and sort of complaining to my front desk that Galina is not working today. Why did you schedule me today? So it's challenging because they're students and they have their own schedules. So then we have the language line, but it's quite interesting and a unique model that I really like. And then this ties into our podcast today, because when I met these amazing superstars, I thought we need chiropractor involvement in our primary care networks and our primary health, because it's sort of a black box. In medical school, we're not taught so much about even physiotherapy, about moving, about chiropractor stuff, about naturopathic stuff. But in real life, we're seeing all these collaborative healthcare workers and patients from them coming to us and asking us questions, and oftentimes we have no clue. So a prime example, in our clinic, when my brother and I first started, we had no clue about what chiropractors really did, and our only thinking was, well, in the emerge, if you have to diagnose a vertebral artery dissection, ask them if their neck has been manipulated. And just for the listeners, evidence suggests that there's no real evidence, there's no increased risk. But that's what we are trying to alleviate by education. We want to make sure people are aware that we have all these healthcare resources that we need to send our patients to and learn from them.
From my standpoint, it's amazing that you come in for this, because I've had the privilege and the honor, I guess, to work, in sport for such a long time with Team Canada and whatnot. And when we're in the world of high level sport, of elite sport, we have sports medicine docs and sports physiotherapists and sports chiropractors and sports massage therapists and an AT, and everybody has that postdoc specialty and whatnot. And there's a full collaboration with that. I mean, even in our fellowship exams, we have CASM docs that are examiners. And at the CASM exam, we have sports chiro fellows that are examiners in their exam. So there's this full collaboration that happens in this closed network with these athletes and whatnot. But then when we get back to everyday healthcare in the city, there's zero collaboration, and there's misunderstanding across the board, right? But it's great that we're doing our little part, which is wonderful, right?
Totally. And part of that also is in our journal club that we do various talks for different new therapies, different new medications, I'm trying to integrate more of our allied healthcare workers. So I've had the honor of having nurse practitioners, you guys invited to some of them, and I'm opening it up, and it's a big challenge because one of the big pharma companies, when I first extended the invite, they just didn't understand. So it's a slow change, but it's always headed in the right direction from what I see. And as healthcare workers, we just need to advocate in our areas for further collaboration.
Yeah, and it's so cool to see. I mean, as a young chiropractor, to see the barriers start to come down a little bit. And I know like this is something that Greg has probably been pushing for a long time, because in reality we're always going to need MDs, and chiropractors are not going away,
and we're always going to need chiropractors.
Yeah.
So we all have to coexist and work together
for sure. And there's a place for all of us here. And I mean, Greg, knowing that when you're providing the best possible healthcare to people that are at the top level of performance when it comes to athletes, the best results are always collaborative. Right. And why not extend that all the way around, all the way through care? So yeah, I don't know. It's refreshing. It's refreshing to see that. And for sure there is chiropractors who are, maybe not the best. There are for sure MDs who probably have been negligent at times. And I think at the end of the day, you can look in any profession, whether a teacher, lawyer, blah, 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 and not to knock on any other profession, but there's always going to be people where you're like, this person is really amazing at this job. This person maybe isn't the best. And I'm sure there are chiropractors out there where you're like, you take that one example and you can extend that across the board. There's some quacks out there. I don't know.
That's just. I feel like that's just a human experience, right? I'm without mentioning the name of the specialty during COVID, when I would refer a patient to the said specialist who's completely MD, have a fellowship, would send me referral notes where I was just like, this is borderline. So any profession can have those, and you can just take that with a grain of salt and try to just educate people based on evidence-based medicine. And I actually have an example of a patient that really benefited from collaborative care. I got one of the first referrals from a chiropractic friend, and this patient was really, really suffering from cervical spine radiculopathy. They were adjusted. Things were better, but their radicular symptoms weren't going away. And that's where we came in and we did some further testing, and we found out that they had thoracic outlet syndrome, amongst other issues. So there's some diagnostic clarity came around. And then how we worked collaboratively was that they were coming in to see us and maybe get a trigger point injection for some relief, or have a shoulder injection, but then go back to their chiro for further adjustment and movement. And that trigger point injection actually helped the chiropractor to do what they needed to do. So that always strikes me as a prime example of how we can always work together. And we do this quite regularly. I had the honor of training with Dr. Babbins for my sports medicine block, and he's an amazing sports medicine doctor, as Greg, you're probably aware. And he taught, and the fact that he taught us to do most of joint injections in our clinic was a really big help, especially in rural medicine, where you don't have the luxury of sending them to a radiology place. So, whenever I think about it, and whenever somebody asks me, what can I do more for my mechanical back pain, for example, I always recommend my chiro colleagues, my physio colleagues. That's what we need. Like, we know that soft tissue injuries will take 4 to 6 weeks to get better. And recently, as I was telling Matt, I injured my foot. And when you go through something personally, you actually realize, like, it's easy for me to say when I see someone in the clinic, oh, there's no fracture, it's going to get better in 4 to 6 weeks, put this diclofenac gel on. But when it happens to yourself, you are like, man, I wish I had some other help or some other resources. And that's where I feel like that's a prime example of where family docs can use these resources and get their patients some help that they need.
Yeah, and for sure, like the physicians that really know, that you can really tell are good at their job, know when they can help someone and when it's time to call in somebody else. And I think that the physicians, whether that's chiropractors, MDs, or anybody else, that become problematic is like it comes from a point of wanting this help to help that person. I think it comes from a genuine place, but it's when you start beating your head against the wall and not being too proud to say that, okay, look, maybe this person needs the next step. Maybe this person needs to go see their physician and get some further imaging and then get some potential surgery candidate. And I think that's hard. And even as a young chiropractor, it's difficult at the beginning to find your place and go, what is for me to handle and what is for me to, because ultimately my job is to get you better. And that means quarterbacking the case when the time comes. And whoever, if I can't get you better, I need to get you to the person that's going to get you better.
Absolutely. And the biggest example of this is during training, the most dangerous aspect of things is when you first come out. So when I first came out and I was working in Strathmore, I thought I knew a lot or whatever. And then when my seniors would take me under the wing or tell me like, maybe you should spend more time with this patient in emergency, it was irritating at times where you're like, you know what, I'm an attending now, I'm staff, I know this. But then looking back at those days and when I do emerge now, I was like, oh my God, I just didn't know so much. And that's something that we're trying to incorporate into our learners today. So when I teach at med school, our biggest thing when we work on communication, collaboration is to know where your limits are and to ask for help. Ask for help early, don't mess up. So that just echoes what you just said.
For sure. And I think that, when you're as a physician, or you get in this position where you get to be the person that holds the power, you get to be the guy in charge that tells people what to do in a helpful way, in a genuine way. Obviously you want to help people, but when you're in that position, it can get to your head. And sometimes it's hard to ask for help, right? And I think we're particularly susceptible to that, right?
And that's why this has been so helpful, just collaborating with these guys, because I've learned a lot, because as I said, my exposure to chiropractors was minimal in the beginning, but then I see a certain approach to chiropractic medicine, and now I'm seeing Greg and Matt's approach to chiropractic medicine, and you guys should come check out their clinic. It's amazing. It's I'm going to try to style my office around this place.
Thanks, appreciate that.
I got nothing else. No, I appreciate you coming in and talking about it and starting the conversation, and then we just basically learn from each other on how we can best collaborate on patient care and get the best outcomes, right? So it's good just learn about what each other does. I think there's this piece that a little bit comes from the true sense of the word of ignorance, is that we just don't truly know what our colleagues, other health professionals are actually doing. We're just, in a truest sense, ignorant to it. And so, like for me, even in this conversation, I'm like, man, there's some physicians out there that I bet you would be amazing to collaborate with, but I don't know their practice focus and I don't know what they do. And I'm ignorant of, their approach and their referral system and all that. So It's just taking the time to actually speak to professional colleagues and kind of get to know and work a little bit better and learn to understand first. It's good. It's good. So I'm super, super thankful you came in to talk.
No, thank you guys for having me. And I feel like through this podcast, if any physicians, family docs, any sports medicine doctors, anybody's listening, and if your patient needs that help, don't be shy to send them to a chiropractor, for example, or any other healthcare provider that might help them. And hopefully through this podcast, maybe one day we can have a big enough group where we can set up like a social event and collaborate and introduce our referral processes to each other. I think that would be very helpful.
Do a few case presentations.
Totally.
Cool.
Build the network. I love it. All right. Well, really appreciate it, Dr. Chatha. You've been great. And we're looking forward to, keeping this connection longer and just growing, breaking down walls between practitioners. So I appreciate that.
Perfect. Thank you.
Thanks for our listeners, guys. Feel free to check us out on Instagram under move2improve_pod. Go and check out Dr. Chatha if you're seeking healthcare at Oasis Medical in Bridgeland. And we'll see you, unless you have something to add. All right. We'll see you guys on the next one.